Well, here we are back for part 2 of Chapter 19's Neurologic Emergencies. We're going to pick up right where we left off. We're going to first talk about some standard care guidelines for the neurologic patient. So when caring for neurological patients, it's crucial to prioritize specific areas that support optimal brain function. This way we can ensure that the body maintains a balanced internal environment, including stable vital signs, fluid balance, and this way it will support good brain health. If we ensure that we're providing essential nutrients, it will be very beneficial to the overall health of the person as well as their brain. Ensure adequate oxygenation through proper respiratory support. Monitor, maintain normal glucose levels as the brain relies heavily on glucose for energy. We should also make sure that we're maintaining a normal body temperature to prevent hyperthermia or hypothermia, which can negatively impact brain function. Be sure and follow established care guidelines that provide a framework for assessment and intervention. This foundation can be adapted based upon the specific neurological condition that is being treated, such as stroke, seizures, brain trauma, etc. This table here shows the standard of care guidelines for the adult neurologic patient. Of course, the main thing we want to start off with is ensuring that the airway is clear, and then evaluate the effectiveness of using that protective equipment as needed. Check vital signs, make sure we got a good baseline, monitor for hypovolemia, and consider fluid administration when necessary. Make sure we measure make sure we're measuring glucose levels to rule out hypoglycemia, especially in patients with altered mental status. Monitor symptoms of intracranial pressure and implement a management strategy whenever necessary. Regularly evaluates the patient's cognitive status and responsiveness, and be wary and watch real closely for changes in consciousness and changes in behavior. Keep thorough records of assessments and interventions to guide your ongoing care. Make sure all that gets documented. When treating hypoglycemia in a neurologic patient, the administration of dextrose is a common intervention. However, we need to follow a few guidelines. Consult with local protocols to determine the specific blood glucose threshold that is considered low and warrants treatment in a patient with suspected neurological problems. Of course, when available and when necessary, if we need to give dextrose will rapidly increase the blood glucose levels when needed. Glucose is an alternative to that, and it can treat severe hypoglycemia, mainly when we don't have access to good intravenous access. Just remember, glucagon is going to take a little bit longer for it to act. Before administering dextrose, make sure you got a good IV. It's kind of a requirement. Make sure it's good and patent, and there's no chance of that dextrose going anywhere other than in the vein. Remember, dextrose is a very necrotic and necrosis-causing agent. If it gets outside the vein, it's not good for other things. The effects of dextrose usually will begin to happen within 1 minute of administration. It can happen relatively quickly. After administration, monitor the patient's response. If there's no improvement in blood glucose levels, make sure that your IV is still good. And if the first dose is ineffective, you may have to look at administering a second dose, so long as your protocol will permit such a thing. All right, so if an IV can't be obtained, glucagon's going to be the alternative. We're just don't have much of a choice. The level of consciousness and blood glucose levels should increase within 20 minutes after the administration of glucose or glucagon. They may or may not be already at the hospital by this time, but for those of you with long transport times, you may begin to see the effects of that glucagon beginning to work. The dose can be repeated up to a maximum of 3 doses if necessary, of course, following protocol. And currently there's no safe method to decrease blood glucose levels in the pre-hospital setting. So if you've got a patient that's hyperglycemic, there's just not any real effective way that we can do that in the field. that is worth even pursuing. Many times it's either going to be a dialysis situation, or they'll use fluids to kind of help to correct things, and it's going to be a slow process to get things back in order. Administering insulin can actually lead to overcorrection and causing the patient to enter a hypoglycemic state, so we don't typically mess with that. In severely dehydrated patients with hyperglycemia, rehydration can help lower blood sugar levels. However, this must be done really carefully, and it may take a very particular fluid. So what we do in the field we may give a small amount of fluids compared to the fluids that they'll give in the hospital, and they may give a fluid that's different than, say, normal saline or lactated ring or something along those lines, just because it will be more effective. Sometimes we got to administer Narcan in the field whenever we have a neurologic patient that we suspect of having some kind of narcotic on board. Of course, it's primarily used to reverse the effects of opioid overdoses. In particularly, what we're looking for is its assistance with respiratory depression. It can be administered through several routes depending on the situation and what you have available to you. We can give it directly in the bloodstream by IV. It will have a very rapid effect, or it can be done IM, which is more of a systemic absorption. Can actually even be done down the endotracheal tube, and of course, through a mucosal atomizer, nasally it can be given as well, which is really the common route that we see in the pre-hospital setting because it's the least invasive of any of them. When responded to a suspected opioid overdose, it's important to gather any information you can get about any previous Narcan administration, like prior to your arrival. Not that they had it 2 years ago, which might be noteworthy, but if they had anything prior to your arrival and you wanting to give them Narcan, just so you know what you're up against. Talk to bystanders who may have witnessed the event or provided care prior to your arrival. Be sure and ask the key questions you need to ask. Ask them, confirm whether Narcan has been administered to the patient, how much was given, when was it given, and what was the route that they gave it, so that you have a better understanding of kind of what you're getting yourself into. When managing a patient with signs of increased intracranial pressure, we need to be sure that we maintain and use prompt and effective interventions, because that's the most essential thing that we can do. Secure an IV and administer fluid as needed. Of course, normal saline, lactated ringers is the solution that's preferred. Do not use solutions that contain dextrose, as they can make things worse in cases of cerebral edema. Watch the blood pressure and pulse rate to keep an eye on their hemodynamic status. If the patient is hypotensive, implement measures to support blood pressure to maintain adequate cerebral perfusion. Remember, the target is we're going to try to maintain a blood pressure of somewhere around 110. We don't want to go much over that or much under that to ensure that we're getting good brain perfusion. Perform continuous heart monitoring using an EKG to detect any arrhythmias or changes in cardiac function as we're going through it as well. The next section, we're going to talk about some common neurological emergencies that we see in the field. It's important to point out is how susceptible someone is to a particular disease often arises from multiple factors rather than a single cause. In the early development stages, there can be significant things that will influence long-term health. Genetics and environmental factors during this period may predispose individuals to certain diseases. The immune system also plays a crucial role in protecting us against pathogens, and the body's ability to repair and regenerate tissue also impacts the disease susceptibility. A compromised immune system response or inefficient repair process can increase the vulnerability. Environmental exposures such as toxins, infectious agents, and other harmful substances can trigger disease processes as well. The nature and duration of the exposure, along with individual susceptibility, will be the biggest determining factors on their health and the outcomes. And when we talk about stroke Stroke occurs when the blood supply to an area of the brain is interrupted, leading to ischemia. Of course, timely intervention is crucial in improving the outcomes. About 75% of all stroke patients are over the age of 65, but it's no set in stone guarantee that the only people that have strokes are the older people. They can happen in younger folks as well. The American Heart Association reports that significant number of stroke patients either deny or do not recognize their symptoms, which can delay treatment. Prompt identification of stroke symptoms is essential if there's any chance of reversal of the permanent damage that strokes can cause. Appropriate and timely medical intervention can significantly improve those recovery outcomes. About 1/5 of patients with intracranial hemorrhage may experience a significant decrease in their level of consciousness between the time of the emergency medical services provide care and when they transfer them to the hospital. So intracranial hemorrhages are the toughest ones to deal with. Remember, time is brain. We use that term with heart conditions, heart attacks and those kinds of things. Time is muscle. Well, time is brain too. So time is neurons. So we measure time in the amount of neurons that someone is going to lose the longer we take. We need to make sure that this is emphasized and underlines the importance of stroke treatment. Delays will result in increased brain damage and worse outcomes because more and more neurons will be lost the longer we delay care. The pathophysiology of stroke often has a vascular origin leading to neurological conditions. So it does tie in pretty closely with the cardiovascular system, mostly the vascular side of the cardiovascular system, but the two do go hand in hand. Strokes can be broadly classified into two types, ischemic and hemorrhagic. Sudden occurrences oftentimes are the result of an ischemic stroke that are typically caused by an emboli, which are just essentially blood clots traveling from one part of the body to another, and they wind up getting lodged in the brain and they obstruct airflow. The other is hemorrhagic strokes are often the result of a rupture of an aneurysm, which is a weakened area in the blood vessel wall that bulges and then eventually can burst, leading to bleeding within the brain. Very hard to detect these, and these are the ones that happen with very little or no warning, that they're coming. So as mentioned though, an aneurysm is a weakness in the layers of the arterial wall and can develop through a specific process. It starts with small tears in the arterial wall, which can happen due to factors like high blood pressure, atherosclerosis, or even traumatic events. As blood seeps between the layers of the artery, pressure begins to build up, causing the initial small tears to grow larger. If the damage gets severe enough, the artery may leak or even rupture, leading to an intracranial hemorrhage, which can result in a stroke or other serious complications. There are two types of stroke. About 87% of them are ischemic strokes. Only about 13% are hemorrhagic. The pathophysiology of ischemic stroke is as follows. Also can be known as occlusive strokes. They're caused by an occlusion or a blockage, and this can be either a thrombus or an embolus. So it can be a clot, or it can be a fatty embolism or some other foreign object, traveling through the blood vessels. The blood vessel becomes blocked, causing tissue beyond the clot or beyond the blockage to become ischemic. The tissue will eventually die if circulation is not restored. And of course, the amount of the brain involvement is limited to the tissue beyond the blockage. So depending on what area of the brain loses blood supply, that's the area of the brain that's going to be affected by the stroke. The severity of the stroke is dictated by the size of the artery involved and the portion of the brain being denied oxygen. The larger the artery, the bigger impact that it's going to have, or the particular portion of the brain may affect vital parts of the brain that are essential to survival. In hemorrhagic stroke, they tend to get worse over time because of the bleeding within the cranium. This bleeding causes increases in intracranial pressure and can lead to brainstem herniation. The primary symptom is generally a complaint of the worst headache of my life. It's typically what we hear from these patients. They won't present like, with hemiparesis or hemiparalysis so much as, there's something abnormal, something going on in the brain. They might have some pupil changes and that kind of stuff as well, depending on how large the bleed is. And over time, these will get significantly worse. They can be treated. The treatments doesn't have the best prognosis as, the ischemic strokes do, but they can be treated, and sometimes they do lead to full recoveries. Remember, the skull contains 3 substances: the brain, blood, and cerebral spinal fluid. All 3 of these exert pressure against the inside of the skull, the walls of the skull, and the exchange of pressure between these substances is typically balanced, or it should be in balance. With intracranial pressure, normally measuring between 10 and 15 millimeters of mercury in adults and less than 3 to 7 in children. However, when this pressure rises and remains elevated, it can lead to ischemia of the brain due to decreased blood supply. Remember, as that brain swells, it's going to restrict the volume that the arteries have in the brain. It's going to reduce the blood supply. The pressure of blood within which results in a drop in cerebral perfusion, a drop in the blood pressure in the cranial vault, with normal supply ranging from 70 to 90 millimeters of mercury, and ischemia will begin when it falls below 50. And all intracranial pressure continuously, and all while this pressure continues to fluctuate. So when that pressure drops below 50, that's when we're starting to reach the point of critical mass. The brain's going to start to sustain damage once the pressure drops that low. And as the pressure increases in the brain, it's going to continually begin to choke off the blood supply. And this graph kind of shows a little bit of insight into the progression of a stroke, ischemic versus hemorrhagic. And you can see with ischemic, we've got a little more time. At least it gives the appearance that we've got a little more time, which we do. There is a little more time to turn things around. With hemorrhagic, they typically get bad worse, and the signs and symptoms show up more quickly. Ischemic, the signs and symptoms show up a little more slowly, and they kind of plateau. So that's why sometimes people don't take these things real seriously when they happen. So what happens when things continue to climb and grow out of proportions? A herniation may occur. This involves a shift in the intracranial contents within the cranial vault, or a displacement toward the foramen magnum, which can ultimately compress the brainstem, leading to a loss of control over autonomic functions, respirations, heart rate, blood pressure, all of those kinds of things. Additionally, a large vessel occlusion results from blockage in a major artery of the brain, causing significant portions of the brain to lose blood supply and disrupting higher order brain functions, necessitating advanced stroke care at a facility capable of doing endovascular therapy, as pre-hospital evaluations cannot distinguish between large vessel occlusion and a small vessel occlusion, requiring the treatment in the emergency department to make that distinction. So it's important that we transfer these patients to the proper facility so that they can be treated, but there is a time frame. There is a deadline to this. It needs to be done within a certain window of time in order to stave off, damaging the brain. So when we're assessing a patient, we want to look for these signs and symptoms that are listed here. Slurred speech, aphasia, or trouble understanding or speaking when they don't understand what somebody is saying. It's called aphasia. When they have trouble recognizing things or other people, it's called agnosia. And apraxia is when they have problems coordinating movements, the movements needed for speech. They just have difficulty with that. They might have some movement issues such as hemiparesis, where there's paralysis on one side of the body, or hemiplegia, where there's complete paralysis. Hemiparesis is weakness on one side. Hemiplegia is paralysis on one side. It's easy to get them mixed up, and So you got to kind of keep them straight. But either one is a significant finding. Arm drift, they may have an arm drift when they raise both hands. One side of the face may sag. They may have what's called ptosis or a facial droop. Tongue deviation, that's one of the reasons why we have them stick their tongue out, so we can kind of see that if their tongue is centered in their mouth. Problems eating or drinking. Clearly, we shouldn't let our patients that we believe are suffering from a stroke of any kind eat or drink anything. Drooping of one eyelid, or the lack of coordination and balance are all signs and symptoms that we want to look for. Lack of coordinated and balance is ataxia. Big fancy word for that. When it comes to the effects of a neurological emergency, there are a few key things we need to watch out for. Sensory effects might include sudden severe headache, often described as typically was what we see with a hemorrhagic stroke, and it's often referred to as a hemorrhagic headache. Sudden vision loss or blindness in one eye, or tingling or numbness on one side of the body, that's called unilateral paresthesia. We might see some cognitive effects that show up, such as confusion or decreased level of consciousness. You might also see difficulty thinking or even seizures. The person might even be slipping in and out of a coma or in and out of consciousness. Cardiac effects are also something that we need to keep an eye on. One common sign is high blood pressure or hypertension that oftentimes goes with brain injuries, which can be an indicator of increased stress on the body or increased pressure in the brain. When you're assessing a stroke, a great way to remember what to look for is the mnemonic B FAST. B space fast. So the B stands for balance. Check and see if the person's having trouble with their balance. E is for eyesight. Ask about sudden vision changes, blurredness, make sure they can see from both eyes. F is for facial droop. Ask them to smile. Does one side of their face droop? Do they have an even smile? A is for arm drift. Have them hold both arms out in front of them. Is one arm drifting down? S is for speech. Listen closely. Listen for slurred speech or trouble speaking. Make sure that that's normal or abnormal for them. And of course, T is for time. This is the most important one. Time is critical for stroke patients, so don't wait. We want to make sure that we want to get their treatment started right away. We need to know those time frames. They're important. Among these signs, keep an eye on the vital signs. Elevated blood pressure, for example, can sometimes signal increased intracranial pressure. Other signs of this increased pressure can include things like abnormal posturing, irregular breathing patterns, and unequal pupils. Remember the whole Cushing's triad thing with blood pressures and pulses. Those are all findings we need to be aware of and be on the lookout for. So, how do we manage these patients? Of course, we're going to start with the basics. We're going to start things off with those standard care guidelines. Of course, they are absolutely your best friend in making sure you cover all the necessary steps. Make sure you're continuously monitoring the patient with an EKG. It's really, really important to track their heart rhythm throughout the entire process. It's a good idea to draw blood for a later evaluation if it's possible. Just remember, don't let that slow you down. Transport is still the priority, so don't get caught up in the little stuff. If your patient has a fever, make sure to contact medical control. It's always better to keep the lines of communication open whenever possible. And of course, we should keep the patients supine unless they're showing signs of hypoxia or they're just too uncomfortable laying flat. Remember, their comfort and safety come first. So we don't want to make things worse by forcing them to lay supine if they just can't do it. All right, so this slide here, this chart here talks about the different types of stroke centers that are available to us out there. And all stroke centers have been categorized. So, whether you're looking at an acute stroke ready hospital, that means they have a 24/7 team. They're ready to go. They can handle it. If it's a stroke center, they have a dedicated team and emergency services available. They have neurological care beds and those kinds of things. but they may not have a 24/7 team. Then they have the thrombectomy capable stroke centers. It has all the capabilities of the primary and maybe be able to do some advanced neurological intervention therapies. And then, of course, the comprehensive stroke center, they're able to do everything. They're the ideal place, full range of neurologists and neurosurgeons. They handle most complex stroke cases, including hemorrhagic. So we'll have some local hospitals will be stroke ready hospitals, and then some may be primary stroke centers, but the comprehensive stroke centers are probably mainly what you're going to see in the larger communities, the larger cities and places like that, because they can essentially take care of all the needs for that particular stroke patient. And of course, that would be the gold star, the highest level of place that we can get them to. But remember, if you're having to make a choice between destination and time, choose time over destination for most cases, because taking them to a thrombectomy capable stroke center and versus driving an extra 2 hours to get to a comprehensive stroke center, obviously take them to the closest one, the thrombectomy capable one. So make sure that when you're making those decisions, you're making them with the time factor in mind. All right, for patients who are unresponsive and showing signs of increased intracranial pressure, be ready to administer some fluids as needed to maintain somewhat of a normal blood pressure. Elevate the patient's head about 30 degrees unless you suspect there's a spinal injury. This can help with some circulation. It'll help give you a little bit of venous return and ease some of the intracranial pressure. Always keep the head and neck in a neutral position without flexing the neck. This helps prevent further complications. Keep the airway clear, as always. Don't forget about the airway. It's still extremely important that we maintain a good airway. Be cautious, but suction when necessary. Don't get too crazy about it. We don't want to be too overbearing and cause more harm than good. Keep an eye out for any signs of seizures. If they occur, be prepared to administer some benzodiazepine to help manage them. Remember, not every seizure is a full-blown tonic-clonic seizure. You could have some seizures that look a little different, so keep an eye out for abnormal behavior that could be a seizure. The patient might be bradycardic. Remember Cushing's triad, they might go bradycardic on you. In this case, atropine might be useful, or even transcutaneous pacing if indicated. So focus on monitoring their heart rate closely, but by all means, make sure you follow your protocols on that. Finally, keep a close watch on the patient's blood pressure. It's crucial to ensure that they're stable throughout your care. And one of the best ways to do that is to keep an eye on that blood pressure. So remember, most essential element is time. Time is neurons. The more time we take, the more neurons are lost. From time is brain. So along the way, we should also keep an eye on CO2 levels. That will give us an idea of what's happening at the cellular level in the body and how it's managing the oxygen that we're giving it. If we're having that, cellular metabolism happening. When CO2 levels are too high, it causes vasodilation of the cerebral arteries. This means more blood's going to flow in, which it can increase intracranial pressure. On the flip side, a diminished CO2 level can lower that pressure and can come at a reversing cost by decreasing their perfusion in the brain. So keeping the CO2 levels normal is going to be really helpful. Increasing ventilations can help decrease intracranial pressure. However, it also decreases blood supply to the brain, which isn't ideal. So provide ventilatory support as needed. Use capnography for best results. If you're using end-tidal CO2 readings, aim to be maintained between 30 and 35. That's kind of the sweet spot with them. Regardless of the type of stroke that you're dealing with, time is critical. For ischemic strokes, fibrinolytic agents need to be administered within 3 to 4.5 hours tops. From the onset of symptoms, we got 3 to 4.5 hours. Remember, there may be some flexibility in that time based on the agents given, but we don't have a whole lot of flexibility. That's going to be similar to time frames. I believe the time frames are a little bit longer for removing the clot, but I'm not 100% on that. The situation is a bit different for hemorrhagic strokes. The more the patient bleeds, the higher the risk for intracranial pressure and the potential for herniation. So the goal is to get the bleeding stopped, so we need to get them somewhere that can manage that. There is an algorithm for managing strokes, so we can manage that stroke and just follow this algorithm. This is an algorithm that as you progress throughout your program, you should see more and more of, so it won't be the last time you see it. It's really important for EMS providers to take an active role in educating communities about strokes. Help everyone know what to look for so that they can recognize the signs and symptoms. Share how these strokes can have a huge negative impact on individuals and families, and why it's important to know the signs and symptoms of stroke and to have those healthy lifestyles to prevent strokes. Teach the community how to quickly and effectively call for help when it is needed. And every level of EMS provider must be trained to recognize stroke signs and symptoms. This is crucial for timely intervention, and this is pretty standard across the board. But this is something that we should be revisiting regularly throughout our careers, as treatment regimens and all that change. So we need to stay up to date on that. Remember, IV fibrolytic agents need to be given 3 to 4.5 hours after the stroke's onset. Timing is everything. Once we get outside of that window, there's no way we can give those agents. So this checklist will help you kind of gather the information you need for the ER physician, and that will help them make the consideration of whether or not to do fibrolytic therapy or go in there and pull the clot. It'll help them along the way of making their decision that they're going to make. During your assessment, it's important to use a reliable tool to help you make an accurate stroke evaluation and document it using that tool. One commonly used tool in the field is the Cincinnati Pre-Hospital Stroke Scale. Using this scale can really improve the accuracy of your initial assessment. It helps you evaluate key factors quickly, like facial droop, arm drift, and speech difficulties, so you can make better informed decisions. The tool is simple, it's really fast, it's not hard to use, and it helps you ensure that you're not missing anything when time is critical. Some agencies and organizations rely on or require the use of more than one of these tools, like the Cincinnati Stroke Scale, maybe the FAST Stroke Scale. They might use 1, 2, or 3 of them, and then cumulatively use those to make a decision about where the transport facility is, or what they document that they give to the receiving facility. So also we have the another one is the Los Angeles Pre-Hospital Stroke Screen. It helps you quickly evaluate signs of a stroke like mental status, facial droop, arm drift, and speech issues. Pretty straightforward way to enhance the assessment and make sure you're covering everything. Just like the Cincinnati scale, it's designed to help make the right call quickly and simply. These are no guarantee that they're actually having a stroke, but these give you indicators of whether or not they might be having a stroke, and it helps point you in that direction. It also provides a great means for documentation. There's another one called the Miami Emergency Neurologic Deficit Pre-Hospital Checklist. It's a mouthful. The checklist is designed to guide you through an evaluation by focusing on key neurological signs. It helps ensure you're covering all the aspects during your assessment, allowing for a more accurate and efficient diagnosis. Using this tool in the field can be a helpful way to make sure you don't miss any critical details when you're managing your stroke patient. This one, you'll notice that many of these kind of cover the same topics in some way, but some of them actually have a little different approach to it, or they may look at a different indicator, 1 or 2 different indicators, and that's why some places have their providers do utilize more than one of those scales when they're making an assessment, or a determination whether or not somebody's having a stroke. So, what is standard care? Let's go over some of those key components of standard stroke care. Okay, so oxygen therapy, of course, it's important to titrate oxygen therapy based on the patient's needs. Aim to maintain that SpO2 rate level at about 94. Don't forget to use other assessment techniques to evaluate the need for oxygen. As of now, there are no specific guidelines from the AHA or American Stroke Association for managing hypertension in the pre-hospital setting, but here's a couple of things to keep in mind. Don't give aspirin at this stage. Unless you have a really, really good indication that it's cardiac and not stroke. But the worry with aspirin is we're going to reduce the clotting factor. And if it's a hemorrhagic stroke, we could make things worse. Make sure to protect the patient's extremities from injury. We want to also avoid any further complications. If they have, flaccid extremities on one side of the body that they're unable to control, we want to make sure that, we're not banging them into doors or, getting them caught in bad, in bad places. So when it comes to transport decisions, selecting an appropriate facility is crucial. Always aim to transport patients to a designated stroke center, and ideally the best one that fits within the window of time. Of course, they have a very specialized care need. So if the closest stroke center is more than an hour away, consider air medical transport. Remember, as we've mentioned multiple times, time is of the essence. Time is neurons in this case, so we want to make sure we save all that we can. Before heading out, contact the facility to confirm that their CT and MRI capabilities are optional or operational. This can be easily overlooked, and it can create big time problems if you don't make sure that they know you're coming. This is vital for timely diagnosis and treatment, so we make sure that we don't transport them somewhere that actually can't handle their needs. If possible, transport the patient directly to the hospital CT scanner, where they'll allow you to do that. While en route, EMS should provide a verbal report to the receiving facility. This helps reduce the elapsed time once you arrive, and perhaps you can get that patient right into the start of their treatment. If you're suspecting a hemorrhagic stroke, consider transporting the patient to a facility equipped to do neurosurgery. This ensures that they can get the care that they need as quickly as possible, and that's going to typically be that highest level of facility available. Now, that's not to say that other of those facilities wouldn't have neurosurgeons, but if you're thinking evenings or weekends, that kind of thing, it's going to be much harder to get a neurosurgeon if they're not already on call or already in the facility. So TIAs, what's a TIA? It's a transient ischemic attack, and they're episodes of cerebral ischemia that occur without causing any permanent damage to the brain. You might see them in presentation associated with the stroke. They'll look a lot like a stroke, but they resolve typically within an hour. They kind of go away, and they can have a varying degree of severity. They can be, very severe, with complete paralysis on one side of the body and then resolve within an hour. Importantly, there's no residual damage to the brain once the episode ends. So that's the good news. Typically, these are a warning sign of there's some vascular condition that needs some attention. The fact that more than 1/3 of patients who experience a TIA will have a stroke shortly afterward. So a good timely assessment is crucial. And that way they can make sure that, there's not something that can be fixed. The assessment for a TIA will follow the same protocols as a stroke. So this ensures that we won't miss any critical signs or symptoms. It's going to look like a stroke, and we're going to treat it like a stroke until those symptoms start to fade away. And then we know we're dealing with a TIA. When the symptoms start to fade, everything starts to get better. So, all right, so always make sure that you adhere to the stroke management guidelines. It's strongly encouraged that the patient be transported to a medical facility for evaluation. This is really critical for their safety and health. They shouldn't take this lightly. and you should advocate that they're transported to a medical facility that's capable of doing the evaluation on them that they need. Remember, hypoperfusion is the number one preventable cause of hypertension is the number one preventable cause for strokes and TIAs. It's essential to make sure patients manage their blood pressures effectively to reduce the risk. Encourage the patient to have a conversation with their physician about their condition. This can lead to better management and better prevention strategies. Okay, so comas, not commas. When we're talking about comas, there are a lot of potential causes that could lead to a decreased level of consciousness. It's important to keep in mind and think that through all the possible options here. A helpful way to remember these causes is the AEIOUTIPS mnemonic, which we'll talk about here in a second. Now, when assessing the patient, it's critical to gather some key information. First, we want to find out if the patient was last seen functioning normally. That can give you a good idea of how quickly things progressed. And then we want to evaluate how quickly their altered level of consciousness occurred. Was it rapid or did it come on slowly? So those things are going to give us a good window into what's going on. And here's that AEIOUTIPS tips. And this gives us a mnemonic to follow to kind of maybe determine what might be going on, and gives us some direction to begin our detective work. A is for the first two A's, one's for alcohol and one's for acidosis, and then we got epilepsy, endocrine, electrolytes, insulin, opiates, uremia, maybe there's a problem with the blood. So there's several things in this that we can consider when we're looking for, and this will help kind of provide us a direction. And then tips is for trauma, temperature, infection, poisoning, psychogenic shock, stroke, syncope, space-occupying lesions such as tumors and abscesses, and perhaps even a subarachnoid hemorrhage. This kind of gives us some causes. It's very similar to in cardiac patients, the H's and T's. It gives us a way to kind of look for what might be the cause of this altered mental status, and that way we can begin a more focused look at what's going on. So when assessing for diminished LOC and the potential for an imminent coma, keep an eye out for the following signs and symptoms. Decreased LOC, a noticeable decline in the patient's responsiveness. The patient may seem disoriented or unclear about their surroundings. They might even experience sensory perceptions that aren't present, such as hallucinations. They may develop some false beliefs that could lead to misrepresentations of reality and be delusional. In severe cases, they may develop severe mental disturbances that might affect their thought processes that we typically see in patients with psychosis. Or they could just have challenges in processing information or making decisions. Or it could be just something as simple as an increased drowsiness or lethargy that affects their ability to stay alert. We may see it have some effects on their speech. We talked about speech effects and movement effects earlier. So they may have slurred speech, agnosia, apraxia, aphasia, their ability, agnosias, they have trouble recognizing objects. Remember, apraxia is difficulty with the motor skills required to create speech. Aphasia is they have the inability to communicate, whether speaking or understanding, they have difficulty with that. And then the things that affect their movement, such as lack of coordination or unsteady movement that we see with ataxia, difficult swallowing, which is aphasia, and then seizures and maybe even posturing, can indicate severe neurological impairments. All the way up to the point where that someone is completely unresponsive and they don't respond to any stimuli, indicating that they're kind of at a critical level of diminished level of consciousness. So this figure kind of shows an algorithm based on that mnemonic we discussed earlier, which can be really helpful in guiding you through the assessment and helping you determine the most likely cause of the altered level of consciousness. By following the algorithm, you can systematically work your way through the potential causes. Whether it's trauma, infection, poisoning, or something else, this will allow you to focus your treatment and move on to the appropriate area of your protocol. It's a great tool to ensure that you're covering all the bases and progressing in a logical and efficient way. It would be extremely difficult to try to remember all of those things that's listed in the AEIOUTIPS mnemonic. It would be very difficult to remember all of those, so it's really handy if you carry a field guide with you that has all of those in it, so then you can just go right down the list, working your way through them. Now, you want to ensure that the vital functions are maintained. This includes monitoring, supporting breathing, circulation, and other critical needs, and collect as much information as possible about the potential causes of the altered LOC or coma. This is critical for effective treatment. Continue your investigation through the underlying causes by checking for medical alert tags, looking through their medical history, getting with family or caregivers to find out more about them, looking for signs of trauma and any kind of physical injuries. Be observant for signs of any kind of drug use. If you suspect that they've taken a narcotic, then administer some Narcan. Make sure that you inform the emergency department staff that you don't know what's wrong with the patient, that you have no clue about what's going on. Provide a report on what you do know, including any conditions or issues that have been ruled out. Okay, there's part 2 in the books. We'll see you back at part 3.